Good evening, everyone. Am I audible and visible? Please update me in the comment section. Yes, we can start now. Thank you. So welcome back to the session, high topics part 2 for the OB-GYN. So we are done with the part 1 and we are done with the PPH, postpartum hemorrhage, antepartum hemorrhage and uterine inversion. So now today what we are going to discuss about is few again important topics that have been asked repeatedly in the exams. So without any further delay, let's begin with the part 2, obstetrics and gynecology. Okay, meanwhile if you have any doubts, keep asking and keep answering, because most of you have revised your note once, so this will be a quick revision session. Okay, now start with the first question of the day. A 32-year-old woman presents to the gynecology clinic with the complaints of chronic pelvic pain. A female is coming to you. She's 32 years old. She is coming to the clinic with the complaints of chronic pelvic pain and dysmenorrhea that has once over the past 1 year. She describes a deep dyspareunia and occasional bloating. Her periods are regular but are associated with the dysmenorrhea. On examination, she has a tenderness in the lower abdomen and particularly in the adnexal region. TVS reveals a 4 centimeter cyst in the left ovary. What is your likely diagnosis? What will be your likely diagnosis? Write down in the comment section what will be your likely diagnosis. So you have a keywords always in a clinical case. Try to find the keywords that are being given in the question. She's a female coming to you with the complaints of chronic pelvic pain, dysmenorrhea, dyspareunia, age is 32, and she has a 4 centimeter cyst in the left ovary. She has a 4 centimeter cyst in the left ovary. So what is your likely diagnosis? Yes, write down in the comment section what is your likely diagnosis. I'm getting multiple answers. What will be your likely diagnosis? Okay, let's understand a full topic. Okay, then let's get back to the question. So likely diagnosis is endometriosis. So likely diagnosis is endometriosis. Now what exactly is endometriosis? What exactly is endometriosis? Endometriosis means that there is an ectopic endometrium tissue present outside the uterus. That means ectopic endometrium. Okay, so what is endometriosis? It means ectopic endometrium outside the uterus. And ectopic endometrium outside the uterus. Okay, if we talk about the etiology of this endometriosis, it's believed that the theory is there which is called as Sampson's theory. It's the most common and most acceptable theory. What is the name of the theory? Sampson's theory. The Sampson's theory says that this is due to the retrograde menses. What is retrograde menses? The backflow of menses, which means backflow of menses. Backflow of menses. Now most of the females have a backflow of menses, but only the females who have a low immunity, they develop endometriosis. Females with low immunity, they develop endometriosis. Okay, now if I talk about the most common age group, that is going to be 25 to 35-year-old ladies. So the age group is around 25 to 35-year-old ladies. If I talk about the investigation of choice, this is your PYQ. The investigation of choice is laparoscopy. The investigation of choice is laparoscopy. But if they ask gold standard, then that is going to be your histopathological examination. That's going to be your histopathological examination, HPE. Okay, now if we talk about the most common site of endometriosis, first one is going to be your ovaries. The most common site is ovary. If I talk about second most common site, the second most common site is pouch of Douglas. The second most common site is pouch of Douglas. Okay, then it's ligaments and further. Okay, but remember the first two things, the first two most common site is ovary, second most common site is pouch of Douglas, and the least common site, if I talk about the least common site, that's going to be your spleen and CNS. Spleen and CNS. Spleen and CNS. Okay, and this is going to be the chocolate cyst of the ovary. What is this? That is chocolate cyst of ovary, and this chocolate cyst of ovary is seen in endometriosis. It is seen in endometriosis. What exactly is inside the chocolate cyst? The chocolate cyst consists of a old blood, okay, old blood debris, okay, that is called chocolate cyst. Now if we talk about the pathological features or the laparoscopic findings of endometriosis, we have powdered burn lesions. We have powdered burn lesions. That's going to be point number one. Second one, we have chocolate cyst of the ovary. Second one, we have chocolate cyst of ovaries. Okay. Next, on findings, we have uterosacral ligament nodularity. Uterosacral ligament nodularity. Uterosacral ligament nodularity. So powdered burn lesions, chocolate cyst of the ovary, and uterosacral ligament nodularity are the classical features of a patient having a endometriosis. Okay. Now these powdered burn lesions, this is the classical picture of what? Powdered burn lesions. Powdered burn lesions. Laparoscopic view of powdered burn lesions in endometriosis. And this is going to be a chocolate cyst of the ovary. Now, what are the symptoms the patient will complain of? What are the symptoms the patient will complain of? The first symptom is going to be the painful menses. The pain during the menstruation is called as dysmenorrhea. So, first symptom is patient coming to you, 25 to 35-year-old lady coming to you with the complaints of dysmenorrhea. Next is dyspareunia. Next is dyspareunia. What is dyspareunia? Dyspareunia means a painful intercourse. Dyspareunia means painful intercourse. Next, a patient can complain of menorrhagia as well. Patient can have menorrhagia as well, and also patient can complain of infertility. Okay, why? Due to the scarring and adhesions. Due to the scarring and adhesions. Due to the scarring and adhesions, patient can complain of what? Patient can complain of infertility. Is that clear? So what is the classical presentation of a patient of an endometriosis? So the first thing is going to be a patient, 25 to 35-year-old lady coming to you with the complaints of dysmenorrhea, dyspareunia, and there is a 4 centimeter cyst. Your likely diagnosis is endometriosis. Their likely diagnosis is endometriosis. Ovarian cancer will have other features. Okay, there will be a weight loss, chronic pain, other things. PID, patient will complain of a fever. Patient will complain of a fever because there will be an infection present. If I talk about PCOS, the patient will complaining of hyperandrogenism. There will be a classical feature of hirsutism, acne, or patient will have anovulation, patient will have amenorrhea. Okay, so all these things are key diagnosis for the endometriosis. Is that clear to everyone? Yes, write down in the comment section. Is that clear to everyone? Next, now let's talk about the treatment. Now let's talk about the treatment of endometriosis. Now first of all, if I talk about medical management, as the patient is just young, so endometriosis is more upon medical management than a surgical management. So medical management, first line drugs that we give now the medical management depends upon a type of a pain, whether the patient is having a mild pain or moderate or followed by severe pain. Is that okay? Now if I talk about a mild or moderate, mild or minimal pain, the first line drugs that you have to start with if there is mild pain, then the first line drugs you will start with OCPs. You will start with OCPs. Okay, the first line drug in case of a mild pain, you start with the OCPs. But if a patient wants to conceive, then your drug is going to be NSAIDs. Then you are giving NSAIDs. Okay, first line drug, you are starting with the OCPs. Then if she wants to conceive, stop the OCPs and give NSAIDs. Okay, second line we start with a progesterone. So what is the progesterone we use? We can use a IUCD containing a progesterone, LNG, Mirena 3rd generation, or we can use an injection, DMPA. What is DMPA? It is depot medroxyprogesterone acetate. So what is the action of this drug? This drug will cause an atrophy of the endometrium, because the main goal in the endometriosis is the atrophy of endometrium. So what will be the action of this DMPA? It will cause atrophy of endometrium. It will cause atrophy of endometrium. Atrophy of endometrium. Is that clear? Now how much to use? 150 mg once every 3 months. You have to use 150 mg once every 3 months. Okay, and the same drug, depot medroxyprogesterone acetate, is used in one contraception. What is the name of the contraception? Anyone in the comment section? What is the name of contraception in which we use medroxyprogesterone acetate? What is the name of the contraception in which we use medroxyprogesterone acetate? Yes. What is the name of a contraception in which we use depot medroxyprogesterone acetate? Very good. Excellent. Antara. Okay. And this depot medroxyprogesterone acetate, it is used in a contraception Antara. It's also used in a contraception Antara. Okay, followed by that we can also use, so we are using progesterone, DMPA, we are using OCPs. We can also use the GnRH analogs. We can also use GnRH analogs like naferilin, buserelin. Okay, followed by that we use a one drug called as danazol as well. And this danazol, it has an anti-estrogenic action. Now we already know that estrogen, if we talk about an endometrium normal, if we talk about a normal physiological process of endometrium, the endometrium grows in the first 14 days of a proliferative phase, and then it becomes secretory in the next 14 days. But the hormone that acts on an endometrium in the proliferative phase is going to be estrogen. So what is exactly the function of estrogen? Estrogen helps in the proliferation of endometrium. Okay, now if I am giving danazol, it has an anti-estrogenic action. It has an anti-estrogenic action, and this anti-estrogenic action will cause what? It will cause faster atrophy of endometrium. It will cause faster atrophy of endometrium. It will cause faster atrophy of endometrium. Okay, and if I talk about a question that is asked, the side effect of this danazol, remember, that is going to be virilization. What is the side effect of this drug? That is going to be a virilization. So what exactly is virilization? It will cause hirsutism, it will cause breast atrophy, it will cause clitoromegaly and hoarseness of voice. And when a patient is complaining of a hoarseness of voice, stop the drug. Okay, stop the drug. Is that clear? Is that clear? Medical management. So what are the drugs we give? So we are giving OCPs, we are giving NSAIDs, progesterone, GnRH analogs, and danazol. and danazol. Is that clear? Is that clear to everyone? Is that clear to everyone? Write down in the comment section, all of you guys. That's clear to everyone? Chalo. Next. Now what about surgical management? Now what about the surgical management? If I talk about the surgical management, remember guys, for for additions I will go for additions I will do additionolysis. For additions we'll go for additionolysis. For additions we'll go for additionolysis. Okay. For chocolate cyst, for chocolate cyst we'll go for cystectomy. We'll go for cystectomy. Okay. FMG recall question was asked that what is an ideal treatment? What is an ideal treatment for? What is an ideal treatment for the recurrent chocolate cyst? The ideal treatment for the recurrent chocolate cyst is going to be cystectomy. Is going to be cystectomy. Okay. For the deposits, for powder and burn lesions or the deposits, we are going for ablation. For these deposits we are going with the ablation, okay, or fulguration of these deposits. Okay. We can also go for the thermal lasers. We can also go for the thermal lasers, but they have a recurrence. They have a recurrence. Is that clear? So that is all about a surgical management. That's all about the surgical management of the endometriosis. That's all about the surgical management of the endometriosis. Or even sometimes we can go for, to decrease the pain, we can go for pre-sacral. We can go for pre-sacral neurectomy. Pre-sacral neurectomy or laparoscopic uterosacral nerve ablation. That's not called as LUNA. Laparoscopic uterosacral nerve ablation. So this is a surgical management for endometriosis. Is that clear to everyone? Now let's have a quick recap of an endometriosis. A 32-year-old lady will come to you with the complaints of an dysmenorrhea, dyspareunia or menorrhagia. On laparoscopic findings, we have a powdered burn lesions or the chocolate cyst of the ovary. Is that clear? And what is your classical diagnosis? Endometriosis. Sir, what is endometriosis? It means when the endometrium tissue is present outside the uterus. Outside the uterus, the lining is with an endometrium, and if this lining or this tissue is present somewhere else, it is called as endometriosis. Now if this endometrial tissue, if this tissue is present, if within the uterus, it is inside the uterus, which is also called as endometritis interna, and if this endometrial tissue is present inside the uterus or within the uterus, we call it as endometritis interna as well. That is a classical case of an adenomyosis. That is a classical case of adenomyosis. Okay, and usually that is found in middle-aged women. That is found in middle-aged women. So now you do understand the difference between an adenomyosis and an endometriosis. Endometriosis is when the endometrial tissue is present outside the uterus. And what is adenomyosis? When the endometrial tissue is present inside the uterus. It is within the uterus. That's why it's also called as endometritis interna. And usually patient complains of a dysmenorrhea and menorrhagia. Dysmenorrhea and menorrhagia. Is that clear to everyone? And there is a enlargement of uterus. There is a uniform enlargement of uterus. There is uniform enlargement of uterus. Okay, and then we have a lakes of endometrial blood. We have a hypoechoic areas present over the investigations, and the definitive treatment for the adenomyosis is a surgical hysterectomy. That is a hysterectomy. Is that clear to everyone? Is that clear to everyone? Write down in the comment section. Is that clear to everyone? Endometriosis. Anyone? Any doubts in endometriosis? All clear? What exactly is endometriosis? Now, if I talk about the next question related to the same chapter, answer me in the comment section. A 30-year-old woman, a 30-year-old woman presented with a secondary dysmenorrhea. She has been diagnosed with endometriosis. Which of the following drug is not useful in the treating this patient? Which of the following drug is not useful in treating this patient? Now, we have already discussed about the management of an endometriosis. Now write down the answer. Pani, water. Now what exactly is the answer? Yes, what exactly is the answer, guys? Which of the following drug you will not use? Patient is diagnosed with an endometriosis. Yes, the drug that we will not use is estrogen. Very good, because estrogen causes the proliferation of endometrium. And the drug that we have used, progesterone, yes sir, we use the progesterone in the form of a depot medroxyprogesterone acetate. We use a danazole, which has an anti-estrogenic action, okay, which causes the faster atrophy of an endometrium, having a side effects of hirsutism and virilization, okay. And then GnRH analogs like naphirolin, buserelin, okay, all those drugs. Is that clear? Now endometriosis is clear, and I've already discussed a little bit about an adenomyosis. Adenomyosis means that the endometrium tissue is inside the uterus. It's also called as endometritis interna, and patient will complaining of again menorrhagia and dysmenorrhea. Patient will be around 45 years old, okay, and the definitive treatment is going to be hysterectomy. Now let's move to the next question. A 35-year-old gravida 4 para 3 woman with a history of a 3 previous cesarean section. She is found to have an anterior placenta previa. On ultrasound at 28 weeks of gestation. The Doppler ultrasound suggests the abnormal placental attachment. There is an abnormal placental attachment over there with the loss of retroplacental hypoechoic zone and placental tissue appearing to invade the bladder, okay, invading the bladder. So it simply means that the trophoblastic tissue or the placenta is invading. It's invading the myometrium, it's invading the serosa, and it's going beyond to the pelvic structures. That means this placental tissue is invading the bladder, okay. Now what is your most likely diagnosis? So first of all, what is your most likely diagnosis? When the placenta, look at the picture now, see, this is going to be the placenta. Normally this is going to be, it is invading, it is attached to the myometrium. In this case it is invading the myometrium, and in this case it is going and invading the pelvic structures as well. So what exactly can be the answer for this question? Tell me, what exactly will be the answer for this question? Yes, what exactly will be the answer? Chalo, let me discuss the full topic first, and then we go back to the answers. So let's discuss about placenta accreta spectrum or placenta accreta syndrome okay. The first thing, if I talk about what exactly is this placenta accreta spectrum or the placenta accreta syndrome, that means the placenta is firmly adherent to, uterine wall. That's why yes, I will discuss all the options. Let's understand the full chapter first, okay. Now placenta is firmly adherent to the uterine wall, okay. Now that's why this placenta accreta spectrum, it is also called as the adherent placenta or morbidly adherent placentas, okay. Why they are attached firmly to the adherent wall? It is due to the absence of decidua basalis. Okay, or it is due to the absence of and due to the absence of decidua basalis plus a fibrinoid layer. What is that fibrinoid layer called as? So that fibrinoid layer is called as Nita Bush layer. What is that fibrinoid layer called as? That is called as Nita Bush layer. So if there is an absence of the Nita Bush layer or the fibrinoid layer, this placenta, it starts invading myometrium serosa and the structures. That type of placenta is called as adherent placenta. So we have, depending upon the depth of invasion, we have accreta, we have increta, and we have parcreta. So what is this fibrinoid layer? It is the layer at which the placental separation occurs. It's a layer at which the placental separation occurs. But when this layer is absent, this placenta keeps invading the myometrium first. This placenta keeps attached to the myometrium first, called as accreta. Then it's starting invading the myometrium, called as increta. And when it goes beyond the myometrium, it goes to the pelvic structures, like bladder is the most common one. It is called as parcreta. And yesterday I have told you, now if this, you have a patient having a case of an adherent placenta, patient is having a increta or the parcreta type of a placenta. Okay, now if we try to take out this placenta, if we try to manual removal of this placenta, there are most chances that it is difficult. Now the placenta is attached till the bladder, it will be difficult. So along with placenta, uterus also comes sometimes. That's why I have mentioned yesterday, the cause of uterine inversion is also what? Morbidly adherent placenta. Is that clear? Now yesterday I mentioned we have mentioned that this is a condition, uterine inversion. And what can be the cause of this uterine inversion? When a patient can have an adherent placenta. And which adherent placenta is more severe? That's going to be parcreta. When this placenta is going beyond the serosa, it's attached to the pelvic structures. Is that clear? So depending upon the degree, or depending upon the invasion or the depth of an placenta, we have three types. We have increta, accreta, and parcreta. We have accreta, increta, and parcreta. What is accreta? When a placenta is attached to myometrium. When it's attached to myometrium, I call it as placenta accreta. Okay, if placenta invades the myometrium, it is called as placenta increta. And if it invades through serosa, or it goes to pelvic structures, like bladder, it is called as placenta parcreta. So given in a question that patient is having an anterior placenta previa, along with that 28 weeks of gestation, there is an abnormal placental attachment, and it's invading the bladder as well. And invading the bladder will cause which type of placenta? Will cause placenta parcreta. What is the answer, guys? Write down in the comment section. Yes, is that clear now? Okay, now sir, why not placenta accreta? Because placenta accreta is just to the myometrium only. Okay, why not placenta increta? That's attachment invading the myometrium only. Sir, why not placental abruption? A patient will complaining of a painful vaginal bleeding with a tender uterus. So your answer is going to be placenta parcreta. Is that clear to everyone? Yes, chalo. Now sir, what will be the investigation that we do? We can go for the USG, we can go for the Doppler, or MRI. USG, Doppler, and MRI are the investigations that we do for a are the investigations that we go for the placenta accreta spectrum, okay, or adherent placentas. What will be your management? So the management, we go for an obstetric hysterectomy. We go for laparotomy plus laparotomy plus obstetric hysterectomy. Laparotomy plus obstetric hysterectomy. But in case if you are able to save the uterus, because some conditions like increta and accreta, they are not invading more, if you are able to save the uterus, then give a drugs like methotrexate and actinomycin to prevent the trophoblastic persistent of tissues. Is that clear? Because it can be a partial adherent placenta or complete, okay. And if in case you are able to save the uterus, then give the drugs. What are the drugs? I give the drugs like methotrexate plus actinomycin, methotrexate plus actinomycin, in order to prevent the trophoblastic persistence of the tissues. Is that clear? Now next question, which of these placental implantation would most likely cause excessive bleeding? Now which of the following adherent placenta, which of the following adherent placenta among the four will cause the heavy bleeding? Which of the following placenta will cause a heavy bleeding? What will be your answer? Write down in the comment section. What will be your answer? Yes, that's going to be increta and parcreta. That's going to be increta and parcreta. Increta and parcreta. Good. Chalo. Next. Now let's move to the next question. A pharmacological question, guys. A woman who is 6 weeks pregnant, presents to your clinic with a concern about a medication. So she is 6 weeks pregnant. She is concerned about the medication. She is taking isotretinoin, that's your vitamin A, for the acne. Okay, so retinoids, they are drug of choice for the acne. What is the most likely teratogenic effect associated with this drug? So what is the side effect of a drug isotretinoin if used in pregnancy? Write down your answer in the comment section. What can be the answer? Some people with B, some with C. What can be the answer? Isotretinoin side effect. If I talk about a side effect of a drug isotretinoin, it causes craniofacial abnormalities. It causes craniofacial abnormalities. So what are the craniofacial abnormalities? Like, it causes cleft lip or cleft palate. It causes cleft lip and cleft palate. Okay, if we talk about a renal agenesis usually due to the ACE inhibitors in pregnancy. That's why ACE inhibitors are contraindicated. If I talk about a neural tube defects are due to the decrease folic acid, vitamin B9, and they're also due to the anti-epileptic drugs as well. If I talk about cardiac anomalies like Epstein anomaly, that is due to the lithium. That's due to the lithium cardiac anomalies. Is that clear? Is that clear? So what is the answer of the given question? That if a patient is taking a drug isotretinoin, the side effect can be cleft lip and cleft palate. Now let's discuss the teratogens, some drugs and their side effects. Okay, if I talk about anti-epileptic drugs, they cause a fetal Hedon-Twine syndrome. They will cause fetal Hedon-Twine syndrome. So what exactly is the syndrome? Baby will have distal digital hypoplasia. And patient will have upturned nose. That is a side effect of anti-epileptic drugs. If I talk about AC inhibitors or the angiotensin receptor blockers, patient will have fetal renal hypoplasia. Fetal renal hypoperfusion. So what is that? That means there is decreased blood supply to the kidneys. When there is decreased blood supply to kidneys, my dear students, when there is decreased blood supply to kidneys, what will happen? GFR will be decreased. When the GFR will be decreased, there will be less urine, and when the patient is having a less fetal urine, the fetal urine is the most common constituent of an amniotic fluid. So a patient taking AC inhibitors will complain of what? Oligohydramnios. Patient will have an oligohydramnios because fetal urine is the main constituent, and when we are giving an ACE inhibitors, they are causing a renal agenesis. Is that clear? And eventually there is decreased fetal urine, decreased amniotic fluid, less than AFI of 5. The diagnosis is oligohydramnios. The diagnosis is oligohydramnios. If we talk about the alcohol, mother taking alcohol during the pregnancy, it will cause fetal alcohol syndrome. It will cause fetal alcohol syndrome. Okay, there is abnormal brain, there is brain abnormality. There is brain abnormality. There is brain abnormality. Okay, if I talk about the lithium, you already know the lithium is a teratogenic drug. It causes a cardiac anomalies like Epstein anomaly, and in Epstein anomaly we have a classical appearance on the X-ray. We have which shape heart? Box shaped heart. And the side effects of lithium from the pharmacology are very important, guys. They usually ask what are the side effects of the lithium. Remember the side effects of the lithium as LITTH. So these are the lithium side effects. Lithium side effects. So L for leukocytosis, L for leukocytosis, I for insipidus, I for insipidus diabetes. So diabetes insipidus, it can be of different causes, my dear students. This diabetes insipidus can be nephrogenic, okay, it can be neurogenic, or it can be drug induced. And which drug causes diabetes insipidus? Decreased antidiuretic hormone. Which drug causes? That's going to be lithium. And what is the drug of choice for a drug induced insipidus diabetes? Okay, now insipidus diabetes, my dear students, it can be due to 3. It can be sir nephrogenic, it can be sir neurogenic, or it can be sir drug induced. It can be drug induced. If it is due to the nephrogenic, the drug of choice is thiazides. Remember this. If it is neurogenic, the drug of choice is going to be desmopressin. And if it is drug induced, the drug of choice is going to be amiloride. Amiloride. And what is the problem? Increase antidiuretic hormone. Is that clear? Is that clear? So remember the side effect of this lithium, and they have been asked multiple times. The most common side effect is going to be tremors. Most common side effect, if they ask, that is going to be most common side effect is tremor. T is teratogenic. T is teratogenic, and H is hypothyroidism. And H stands with hypothyroidism. So what are the side effects of the lithium? So they cause leukocytosis, insipidus diabetes, tremors, teratogenic, and hypothyroidism. And if I talk about diabetes insipidus, if nephrogenic, the drug of choice is going to be thiazides. If neurogenic, the drug of choice is going to be desmopressin, and if it is drug induced, that's going to be amiloride. Okay, now if I talk about a next drug, that is indomethacin, it causes premature closure of ductus arteriosus. It causes premature closure of ductus arteriosus. Okay, what is the drug you will give to maintain the patency in case you need to maintain the patent? What is the drug we give? We use the drug alprostadil. We use the drug alprostadil. Is that clear? Now next drug, methimazole. Okay, if you use methimazole, what can be the teratogenic effect? Cutis aplasia. It causes cutis aplasia. What is cutis aplasia? It is an absence of epidermis and dermis. And which condition we use this carbimazole and methimazole? If we talk about an hyperthyroidism, okay, you already know two conditions. Either there will be hyperthyroidism or there will be hypothyroidism in pregnancy. You already know what will be the level of TSH in hyperthyroidism. That is decrease due to the negative feedback. Here TSH is increase. So what are the drugs that we use in case of a first trimester? In case of a first trimester, we use propylthiouracil. In case of a first trimester, it is safe because there is no teratogenic effect. But in case of second and third trimester, we use carbimazole and methimazole. We use carbimazole and methimazole. But if we use the carbimazole and methimazole in the first trimester, the side effect that we have is going to be cutis aplasia. And cutis aplasia means that there is absence of epidermis and dermis. There is absence of epidermis and dermis. Is that clear? Is that clear? And what if a patient is having hypothyroidism in pregnancy? What is the drug you will give? Levothyroxine or L-toxin. Is that clear? Is that clear? Hyperthyroidism and hypothyroidism, and what are the possible side effects of the drugs? If you talk about a warfarin, it causes warfarin embryopathy. It causes warfarin embryopathy, and in warfarin embryopathy, baby will have nasal hypoplasia. Baby will have nasal hypoplasia. If we give thalidomide, baby will have phocomelia, abnormal lower limbs. Phocomelia. Okay, if you talk about methotrexate, methotrexate is teratogenic. It will cause a clover leaf skull. It will cause a clover leaf skull or the craniosynostosis. That means the joints and the sutures in the skull, they will fuse earlier. That is craniosynostosis, clover leaf skull. If I talk about paroxetine, that will cause pulmonary hypertension. If I talk about erythromycin, that will cause congenital hyperpyloric stenosis, CHPS. Okay, congenital hyperpyloric stenosis. And if I talk about mifepristone, that will cause Mobius syndrome. The mifepristone will cause Mobius syndrome. So these are all important teratogens that they ask multiple times. Lithium पूछता है, methimazole, drug of choice in hyperthyroidism in the first trimester, PTU, they all ask these questions. Is that clear to everyone? Yes? Teratogens are clear to everyone? Write down in the comment section. Teratogens are clear to everyone? Yes? Chalo. Now let's move to the next question. A pregnant woman with hypertension is currently taking an angiotensin converting enzyme inhibitor, ACE inhibitor. Which fetal complication is the most associated with ACE inhibitors in pregnancy? What is your answer, guys? Write down the answer in the comment section. Now we have already discussed. Write down the answer in comment section. What will be the answer? The answer is going to be C, that is renal dysgenesis and oligohydramnios. That is renal dysgenesis and oligohydramnios. renal dysgenesis and oligohydro. If I talk about option A, cardiac malformations, that is abstinence anomaly with the lithium. If I talk about limb deformities, that is thalidomide, phocomelia. If I talk about neural tube defects, that is anti-epileptics also, but due to the deficiency of a vitamin B9, folic acid. That is why in order to prevent the neural tube defects, it's mandatory to take the folic acid in pregnancy. How much to take, guys? How much to take? 500 micrograms. Okay, but as per the anemia book, Bharat, but generally you give a 0.4 mg of folic acid every day, and if the patient has a history of neural tube defect, that is 4000 micrograms, that is going to be your 4 mg per day. And the most common neural tube defect associated is going to be spina bifida. And the recent question that has been asked, what are the two signs in spina bifida? That's going to be your lemon and banana sign. Is that clear? So remember that as well. Folic acid as per anemia Mukt Bharat is going to be 500 micrograms, and as per normal it is going to be 0.4 mg, but if a patient with history of a neural tube defect, that's going to be 4 mg. Is that clear? So 500 micrograms, 400 micrograms and 4000 micrograms. Okay, 500 as per anemia Mukt Bharat, generally 400, and patient having history of neural tube defect, that is going to be 4000 micrograms. Is that clear? Next question. Okay, about the iron, remember iron as per the anemia Mukt Bharat is going to be 60 mg of iron, and generally if a patient is coming with in a pregnancy other than the anemia Mukt Bharat, if the question asks 100 mg per day, and if a patient is having moderate anemia, then 200 mg per day. And in pregnancy, deworm the patient with the albendazole, because hookworms can cause an iron deficiency anemia. So deworming the patient in pregnancy is also important. Next, a 20-year-old girl presents to you with a cramping abdominal pain. So cramping abdominal pain, it starts at the onset of menses and is more pronounced on the first day. The pain started around the 15 years of age. That means it's the pain during the menses. Which condition is she likely suffering from? So what is your answer? Write down in the comment section. What will be your answer, guys? Now let's understand the types of dysmenorrhea. Let's understand the types of dysmenorrhea. What is dysmenorrhea? It is pain during menstruation. Pain during menstruation. Okay, so we have a different types. The first one is going to be primary or spasmodic dysmenorrhea. What is primary or spasmodic dysmenorrhea? The pain starts 30 minutes before the onset of menses. The pain starts 30 minutes before the onset of menses and stays for 10 hours. Okay, and if I talk about congestive or the secondary dysmenorrhea, it means pain starts 3 to 4 days prior. That means pain starts 3 to 4 days prior and stays throughout the cycle and stays throughout the menses. That's going to be your congestive or the secondary dysmenorrhea. Then we have a membranous dysmenorrhea as well. Sir, what exactly is the membranous dysmenorrhea? Write it down. There is a fibrinolytic system in the uterus. There is fibrinolytic system in the uterus which prevents the clumping or the clotting of the blood. Okay, now if this system is absent, what will happen? There will be more clumping and more clotting of the blood, and that clotted blood needs more contractions to pass, and more contractions will cause pain, more pain, and such type of pain is called as membranous dysmenorrhea. Is that clear to everyone? What exactly is membranous dysmenorrhea? So the fibrinolytic system in the uterus, it prevents prevents the clumping or clotting of blood. If absence of fibrinolytic system, if there is absence of fibrinolytic system, what will happen, guys? There will be more clumping, or more clots, and these clots need more contractions, and that will further cause more pain. And such type of pain is called as membranous dysmenorrhea. Now, is that clear? What exactly is primary, what exactly is congestive, and what exactly is membranous dysmenorrhea? And remember, guys, if a patient is having a mid-cycle pain, that is called as ovulation pain or a Mitchell-Marsh pain. So what exactly is a Mitchell-Marsh pain? It is due to the blood and debris. From the follicles. It's due to the blood and debris from the follicles collected in pouch of Douglas. The blood and debris from the follicles, okay, that's collected into the pouch of Douglas, causing a pain, and such type of pain is called as mid-cycle or Mitchell-Marsh pain. Now, if I talk about the question, a 20-year-old girl was presenting with a cramping abdominal pain. It started at the onset of menses and it's more pronounced on the first day. It started at the 15 years of age. Your answer is going to be, what will be your answer? Write down in the comment section now. What will be your answer for this question? Your answer is going to be spasmodic dysmenorrhea. Your answer is going to be spasmodic dysmenorrhea, which is also called as what? Which is also called as primary dysmenorrhea. Congestive, it's also called as secondary, that is prior 3 to 4 days. Endometriosis, you already know, endometrial tissue present outside the uterus. Adenomyosis, you already know, that is endometrium tissue present inside the uterus. Is that clear? All 4 options are clear. Let's move to the management of the dysmenorrhea. First of all, we are giving NSAIDs in the management. What can be the NSAIDs you will give? So we'll give naproxen, we give ibuprofen, we give mefenamic acid, but usually now we are not using mefenamic acid. Okay, then second one is going to be, we use antispasmodics. What are the antispasmodics we use? We use the drugs like dicyclomine. We use the drugs like drotaverine. Okay, dicyclomine or drotin. Next, we can use combined OCPs. Okay, but cycles will become anovulatory. We can use also GnRH analogs, but GnRH analogs se kya hoga? What will happen? The cycles will be stopped because they will cause the down regulation of the pituitary. Okay, we can go for the surgical treatment as well. What are the surgical treatments that we can go? So we can go for the surgical dilatation of the cervix. We can go for surgical dilatation of cervix, so that it will allow the clots to pass easily, because clots need contraction so that they will pass. But once there will be a surgical dilatation of the cervix, so that there will be less contractions needed and patient will have less pain. Is that clear? Or we can go for pre-sacral nerve ablation. That's the management of dysmenorrhea. That is going to be your management of dysmenorrhea. Is that clear to everyone? Is that clear to everyone? Yes? Now answer me the question. Chalo. A 28-year-old woman reports experiencing sharp localized abdominal pain. She's having sharp abdominal pain that occurs consistently midway through the menstrual cycle. So that occurs like midway. If normal cycle is 28 days, so it occurs midway, 14th day. The pain resolves with a few hours. She has no other symptoms. What is your likely diagnosis? What is your likely diagnosis? What will be the answer, bacho? What will be the answer, guys? She's having lower abdominal pain during the mid-cycle. She's having a lower abdominal pain during the mid-cycle, and the pain resolves within the few hours, and she has no other symptoms. So what will be your likely diagnosis? The answer is going to be your, yes, C. That's going to be Mitchell-Marsh pain. Mitchell-Marsh pain. Is that okay? That is not in dysmenorrhea. We already know dysmenorrhea is a pain during the menses going on, whether that can be a congestive or the spasmodic or primary or secondary. Okay, it cannot be PID because patient is not complaining of any fever. Is that clear? And it cannot be torsion as well. So the answer is Mitchell-Marsh pain or the mid-cycle pain. Mitchell-Marsh pain or the mid-cycle pain. Is that clear to everyone? Is that clear to everyone? Okay, now if I talk about a normal length of the cycle, normal length is 28 plus minus 7 days. Okay, if it is less than 21 days, I call it as polymenorrhea. Remember this. More than 35 days, I call it as oligomenorrhea. If it is less than 2 days or less than 10 ml of blood, I call it as hypomenorrhea. If the blood loss is more than 80 ml, I call it as menorrhagia. I call it as menorrhagia. And normal amount of blood loss during the is around 30 to 35 ml. Okay, but if it exceeds more than 80 ml, that's going to be menorrhagia. That's going to be your menorrhagia. Is that clear to everyone? Is clear to everyone? Yes. Is that clear to everyone? Chalo, good. Now let's have a quick recap of from the beginning whatever we have discussed today. Chalo. First of all, we discussed about an endometriosis. What exactly is endometriosis, guys? Have a quick revision. What exactly is endometriosis? Endometriosis means when the endometrium tissue is present somewhere else. Okay, the most common location is going to be ovaries, followed by the pouch of Douglas, and the least common is going to be spleen and CNS. The investigation of choice, okay, it's a PYQ that has been asked. That's going to be your laparoscopy. And if I talk about a gold standard investigation, that's going to be your histopathological examination. Okay, and the theory that is most acceptable is the Sampson's theory, which says that it is due to the retrograde menses, that is the backflow of menses. But the patient to have a decreased immunity, they will have an endometriosis. Pathological findings, you will remember, powdered burn lesions are there, chocolate cyst of the ovary, there is uterosacral ligament nodularity. And symptoms, patient complain usually the age 25 to 35 with the complaints of dysmenorrhea, dyspareunia and menorrhagia. Infertility is also associated, my dear students, due to the scarring and additions. Due to the scarring and additions, patient can have an infertility. If I talk about medical management for the mild pain, first line we're giving OCPs, and if patient wants to conceive, you go with the anisets. Second line we are giving a progesterone drugs, DMPA, and DMPA causes an atrophy of endometrium. You use 150 mg once every 3 months. We can go for the GnRH analogs as well, downregulation of the pituitary, and anti-estrogenic action with the drug danazol, okay, which causes the faster atrophy of endometrium. But the side effect is going to be virilization and hirsutism. What is virilization? Breast atrophy, clitomegaly and the hoarseness of voice. But the patient, when to stop the drug? Hoarseness of voice. For additions, we go with the additionolysis. For chocolate cyst, you do the cystectomy. For the deposits, you go the fulguration and the ablation, and thermal lasers you can also do, but they have a recurrence rate. You can also go pre-sacral neurectomy. Is that clear? Next, I told you also about adenomyosis. And what is adenomyosis? Adenomyosis means when this endometrium is present inside the uterus. It's also called as endometritis interna, but usually the age group that is there is going to be the 45 to 50, 40 to 50 age group. Okay, and the definitive treatment, if a family is complete, hysterectomy. Remember that the presentation of a patient having adenomyosis and a fibroid is exactly same, but what differentiates is that the fibroid have a uniformly enlargement uterus, but the adenomyosis will have a uniform enlargement of uterus. Non-uniform in fibroids, uniform enlargement in the adenomyosis. Then we talked about an placenta accreta spectrum of the syndrome. That means when there is an absence of a fibrinoid layer called as Nita-Bush layer, and either the absence of a decidua basalis, this placenta invades the myometrium, it invades the serosa, and it goes to the pelvic structures. Depending upon the depth, we have accreta, we have increta, and we have parcreta. If it's attached to myometrium, that's accreta. If it's attached to the invading the myometrium, that's going to be increta, and if it invades the serosa, that's going to be the parcreta. Management, you go for the laparotomy plus obstetric hysterectomy. But sir, if the patient is having placenta accreta, should we go? No, that is a partial one. At that time, if you are able to save the uterus, give the drugs like methotrexate and extomycin to prevent the persistence of the trophoblastic tissues or the other neoplasm that they can arise. Then the most difficult one is going to be the parcreta, because it extends up to the bladder or pelvic structures. That's why this can be the cause of an uterine inversion as well, as discussed yesterday in the part 1. Now the teratogenic effects of the drug. What are the teratogenic effects of the drug? Like isotretinoin, it can cause a cleft lip or the cleft palate. If I talk about renal agenesis, that is the cause of an oligohydramnios, and that is the side effect of a drug of an ACE inhibitors. If I talk about neural defects, I already discussed, that's going to be B9. Cardiac anomalies, that's going to be lithium. Okay, then all the side effects, anti-epileptic drugs will cause fetal hidden twine syndrome, ACE inhibitors will cause fetal renal hypoperfusion, alcohol will cause fetal alcohol syndrome, lithium will cause Epstein anomaly, endomethacin will cause premature closure of ductus arteriosus, methimazole will cause cutis aplasia, warfarin will cause warfarin embryopathy, thalidomide will cause abnormal limbs, phocomelia, methotrexate will cause cloverleaf skull, paroxetine will cause pulmonary hypertension, erythromycin will cause CHPS, and mifepristone Mobius syndrome. Remember the drug side effect of lithium, important ones. And if the diabetes insipidus is due to the nephrogenic cause, you're giving thiazides. Neurogenic, you're giving desmopressin, and drug induced, you give amiloride. And then next one, the question, patient taking ACE inhibitors, patient will have renal dysgenesis, and renal agenesis or renal dysgenesis is the most common cause of an oligohydramnios when the amniotic fluid is less than 5. Okay, then we talked about the dysmenorrhea, the pain during the menses. If it starts 30 minutes prior to the cycle, it's going to be spasmodic or primary. If 3 to 4 days, it's prior. If it's congestive, and if there is an absence of a fibrinolytic system in the uterus, which causes more clumping and clotting, which needs more contractions and more pain, that type of dysmenorrhea is called as membranous. And if the female is having a mid-cycle pain due to the debris accumulated in the pouch of Douglas, that's going to be a Mitchell-Marsh pain. Management, sir, we're giving NSAIDs, antispasmodics, we can use GnRH analogs and OCPs, and we can also go for the surgical dilatation of the cervix. Is that clear to everyone? Yes, and following definitions of that. So we are done for the day. Anyone, any doubts? You guys can watch a part 1 as well. We have discussed multiple topics over there as well, and this video as well at 2x speed, so that it will give boost to your preparation. About the PDF, yes, you guys will get the PDF in the channel FMGE with Dr. Talib Bilal, or either in the MEDUHUB channel. Is that clear? Anyone, any doubts? Anyone, any doubts? All good? Part 3, not yet. But yes, we'll go with the PSM first. Of course, there will be a part 3 as well. We'll see. And in case in the next week, coming weeks, we'll do first PSM full, and then we'll do the part 3, because part 3 will be having main chapters as well, like abortion, we'll take appropriate pregnancy, we'll take labor, and we take some cancers, ovarian cancer and the cervical cancers as the main one. Okay, so keep revising and solve MCQs, and we got this. Okay, See you in the next session. Thank you.